right, Environmental Emergencies, Chapter 31. So we'll start off with cold emergencies. When we're talking about environmental emergencies, we're talking about heat injuries, cold injuries, diving accidents. We're going to talk a little bit about like insect bites, snake bites, that kind of stuff. We're not really going to get into the allergic reaction, anaphylaxis when it comes to certain insect stings and that, because I think you guys have already had it, and there's a whole nother section on allergies. But environmental emergencies, think about things in the environment and how they can hurt us. Okay, so starting off with cold emergencies, the body loses heat a few different ways. Okay, the body can reduce perspiration, so we sweat and that's how our body helps to control our body temperature. Shivering. When we shiver, when we're real cold, it increases the rate in which the fuel is burned. So we can actually, we're going to get cold faster. Because the body's trying to stay warm, but we're burning that energy off. And then soon enough, we're going to get cold and not have enough energy to try to maintain that heat. The body loses heat through conduction, which is the transfer of heat from one material to another through direct contact. Water conducts heat away 25% or 25 times rather faster than still air. So an example would be lying on a cold surface. Your body is touching that cold surface and the heat is being drawn away from your body. Okay, so that's conduction. You put your hand on something hot or cold, okay, and then there's a transfer of heat. Okay, conduction. Convection is when the currents of air or water pass over the body. Okay, so there's airflow and it's pulling heat away from your body. Wind chill is a problem. Faster the wind, the greater the loss. So it can be a little confusing when you think about water. So water conducts heat away, right? So you're just thinking about you're sitting in a pool of water. The water's not moving. Okay, you are actually touching that water. That could be conduction, but as the water moves, if you're in a current, for example, and the water's flowing past you, that would be convection. So water could be conduction or convection. There may be some questions on this stuff in your test. I don't know if I've seen any on the state tests, but we will have some questions regarding these things, okay? Radiation. So heat is picked up by the surrounding air or water. And then evaporation. All right, so we perspire, we sweat, okay, and then respiration, we're exhaling our warm air. So we're breathing out warm air, and that's how our body is losing heat as well, okay? So keep all these things in mind if you're dealing with cold temperatures. We are getting to, wintertime now, although it's really nice today, depending on when you listen to this. So these are the different ways that our body can lose heat. So think about these patients. If you find somebody out in the cold, are they in water? Are they in moving water? Are they just sitting on the ground that's cold? Okay. All right. So generalized hypothermia. Again, hypo would be one of your medical terms, meaning low. So you're talking about low body temperature. The body has lost its ability to maintain a core temperature. Okay, and it will lead to death. Some predisposing factors could include shock, burns, head injuries, alcohol and drugs affected, the inability to move around, and elderly infants and children. Elderly infants and children are kind of their own group of people when it comes to these types of things. And, they will lose their body temperature differently than just a normal healthy adult. So keep that in mind as well. So how do we assess these people for hypothermia? We want to consider the air temperature, the wind chill. How old are they? What are they wearing? What's their overall health? I mean, there are 20-year-olds that are in worse shape than 50-year-olds. So what's their overall health condition? They've been using drugs and alcohol. Okay, these all can affect your patients. So early symptoms, you might see the patient shivering. That's actually a good sign. It means that their body's still doing what it can to keep warm. Okay, at a certain point, they'll stop shivering. That's not necessarily a good thing if they've been on the cold really long. It means their body's not able to try anymore to maintain that body temperature. Okay, Numbness, I think we've all been cold at some point and had numb fingers and that. We know how that feels. Okay, stiff posture, drowsiness. They're starting to have an altered level of consciousness. Breathing and pulse. Early on, they're going to be rapid, right? Because the body's trying to compensate. Later on in hypothermia, you're actually going to see that slow down until they stop. Okay. Early on, the skin's going to be red. And pale and cyanotic in late stages. So the body has, early on, it's going to be red. The body's pumping blood to that area to try to warm everything up. Later on, once it's cyanotic, that means the blood's not pumping to that area anymore, and that's not good. Okay, so how do we treat these patients? We want to remove any of the wet clothing. Okay, we keep blankets. That is part of our 800 that we talked about in the last chapter. We want to remove any of the wet clothing to prevent any hurt and prevent any further heat loss. So get their wet clothes off of them, get them in some dry, warm things. Okay, there's two different types of rewarming, and this is where it gets a little confusing. I want you guys to really study your protocols. It would be a good idea to put those protocols on your phone. I'd recommend it. There's an app for that, and as you're going to these calls, you can flip through real quick just to refresh your memory. But we have our passive rewarming. That's just allowing the body to regenerate its own heat. Okay, that's just passive. We're not actively putting heat onto them. Okay, so passive rewarming is letting the body do its thing. Okay, we're going to prevent further heat loss by putting a blanket on them and keep them in a warm area. But it's still the body that's regenerating its own heat. And then we have our active rewarming. Okay, and that's when we actually take heat packs and we can put them in their neck, their groin, their armpits, and that is us using an outside source to try to reheat the body. But we only do that when the patient's alert and responding appropriately. If they're unconscious, if they're altered mental at all, related to this hypothermia, we don't actively warm. And again, I want you to look at your protocols and really understand these, because it does get a little confusing. All right. So this is really important for you guys to understand. When a patient's hypothermic, you can put them into cardiac arrest very quickly. Okay. We don't let the patient overexert themselves. So if they're sitting in water for really low temperatures and we rescue them out of there and they're alert and they're saying, thank you, whatever it is, they've been in the water for a long period of time, don't let them overexert themselves, because it can put them into cardiac arrest. The hypothermia, along with the exertion, they can put right into cardiac arrest. Okay. If the patient does go into cardiac arrest, we want to start CPR. Generally speaking, the hospital staff we're unable to pronounce death until the patient is fully rewarmed. Okay. There are some caveats to that. Again, look at your protocols and understand when we should be working these patients and when we shouldn't. There is an obvious death protocol. There's certain time frames. If they've been in the water for over a certain period of time, we would have just pronounced that death. Okay. Localized cold injuries. Okay, so we have a couple of different classifications. We're talking like just for example, like a finger. Okay, that would be a localized cold injury. It could be early on, which would be superficial, or late, which would be deep. We're talking about frostbite, that kind of stuff. Okay. Sorry. So early on in the assessment, okay, light-skinned people, you're going to see redness. Okay, dark-skinned people, you're going to see whiteness in their skin. That's early on. Okay, again, this is like we talked about earlier. The early on, it's red because there's blood flow into the area. Later on, it'll look cyanotic. Okay, and the affected area is going to feel numb. Okay, we're going to remove the patient from the cold area. We're going to warm the affected area, splint if necessary. It doesn't mean we have to splint every time. If somebody has a cold finger, we don't need to put a splint on it. But that can keep them from moving it, and we're talking pretty extreme cases. Okay, and then cover it up, keep it warm. Okay, later on, when the skin appears white and waxy, this is further on in the cold injury. Okay, we're gonna see mottled skin. I don't know if we talked about that too much, but it's kind of blotchy looking. Different colors, might be a little bluish and pinkish and reddish and purplish and just weird looking skin. So it can go from blotchy, and then it can go to different colors. So, well, then to white and grayish yellow, then to grayish blue. Okay, different colors, blotchy looking skin. That's mottled. Okay, we're going to give them O2 if necessary. And again, this is late, so this person's been in the cold for a long time. Handle the area gently, cover it. If it's 30 minutes or more transport time, we should look at active rewarming. Technically in the protocol, it says warm bath water no more than 105 degrees until the feeling comes back. That is an option. They can run it under warm water, and if we're at their house. Generally speaking, we want to get moving to the hospital. And we want to dress the area and protect it against freezing. So keep it out of the cold, keep it warm. Okay, pretty straightforward stuff. All right, we have heat exhaustion and we have heat stroke. People get these confused too. All right, but we do kind of need to know the difference. So we'll start with heat exhaustion. Heat exhaustion is prolonged exposure to heat, presents as moist, pale skin that feels normal to the touch. Okay, they're sweating a lot, they're losing salt, it can cause heat cramps. Okay, so think about this early on. You're hot, you're sweaty. Right, and then so our heat exhaustion. We have we're hot, we're sweaty. Okay, that's early on, but we're losing a lot of salt by heavy perspiration. When we move into heat stroke, those temp regulating mechanisms fail. Okay, so you're going to see somebody with hot, dry skin. Okay, it says or moist, but generally speaking, you stop sweating. You get to that point where you pass from heat exhaustion to heat stroke, and you stop sweating. That's kind of the main thing there is a skin condition, and that's why we teach you guys in your primary assessment, the ABCs. The skin condition is part of your C's. If you have a real hot patient, you're doing your ABCs, and you notice, man, they're really hot and dry. They're not even sweaty anymore. This could be heat stroke, and that's even worse than heat exhaustion. Okay, so what are we assessing for? Okay, we're probably going to see things like muscle cramps in the legs or the abdomen. We're going to see weakness, dizziness, rapid breathing, weak pulse, heavy perspiration, loss of consciousness. And again, the perspiration thing, that's going to change when it goes from heat exhaustion to heat stroke. But a level of consciousness change, that's more heat stroke related. Okay. So what do we do? How do we treat these people? We're going to move them from the hot environment. It's kind of obvious, right? Oxygen as necessary. Loosen or remove the clothing. Okay, if they're wearing really heavy clothes and it's real hot out, take it off, cut it off them. Okay, if nothing else, at least loosen the clothing. You know, take their boots off, take their shoes off, get them in a cool area, take the hat off if they got one, that kind of stuff. We want to get them cooled off. Fan them if you can. Supine with legs elevated is the position that we're recommending, which is the same as stroke. Excuse me, shock, not stroke, shock. Supine, legs elevated. If not nauseous, you can give them small sips of water. Use your best judgment with that. You know, we usually don't give people anything to eat or drink when they're in our care. We don't want them to puke on us. We don't want to make things worse. So you can give them little sips if you think it's okay. It's a judgment call. But think that they might puke that back up on you. Okay. We might see altered mental status or loss of consciousness, rapid breathing, full and rapid pulse, weakness, little or no perspiration. And this is the heat stroke again. Okay, we were just talking about heat exhaustion. Now we're talking about heat stroke. Little or no perspiration. We could see dilated pupils and even seizures. Okay, once they get to that point, this is a critical call. We need to get them cooled off and get to the hospital very quickly. ALS, get them on again. Get them to get some fluids in them. Okay, we're going to remove them again. This is the same protocol basically as the heat exhaustion, but the difference is we can actively cool these people. Okay, once we get to the heat stroke, remove the hot from the hot environment, remove the clothing, apply cool packs to the same areas that we talked about with cold injuries, the groin, the armpits, the neck. We can put cold packs there, and that's going to help. Wet sponges or towels is good. Oxygen as necessary. They say to aggressively fan the patient. We want to cool these people off quickly. Okay? All right. Water accidents. Usually this is where we have a group discussion. What are some types, some examples of water accidents? Okay. We have a lake in this county. It's pretty actively used. We have water skiing and boating and scuba diving, and we'll talk a little bit about scuba diving. Just water, diving boards at pools. Okay. Those are different types of water accidents. Drowning. So what exactly is drowning? Here's some facts for you. Okay. Person attempts to take a breath underwater. Okay. Water flows past the epiglottis and triggers the reflex spasm in the larynx, sealing the airway so no water can reach the lungs. Your body's doing this on its own. Okay. Your body almost won't let you inhale too much water. Okay. Unconsciousness. So you become unconscious because you're hypoxic. You're not getting any oxygen. 10% of drowning deaths are from a lack of air. That what it means is, I mean, obviously you don't get all drowning deaths. You're not getting any kind of air, right? But we're referring to the hypoxia here. The remaining attempts to take a final breath. So, the body's trying everything it can to not let water into the lungs, and the person just everything the person has, they just try really hard to take a breath underwater, and they force the water into their lungs. Some patients who drown in cold water, which is considered below 70 degrees Fahrenheit, can be resuscitated after 30 minutes or more in cardiac arrest. There's some really freaky cases out there that people were underwater, actually clinically dead for a period of time, and the cold water, kind of preserved them a little bit. It's not a common thing by any means, unfortunately, but there are some cases out there. It's pretty interesting stuff. So we're responding to a drowning accident. All right, we want to do our ABCs, of course. We're going to check for a pulse. If none's present, start CPR. If there is a pulse, we're going to provide our rescue breaths. And we learned about this in CPR class, so we don't need to really get into it too much. But if a person has a pulse and they're not breathing, we want to breathe for them, right? We're going to use our bag valve mask and give them one breath every 5 to 6 seconds. Keep in mind there may be more resistance because of water in the lungs. C-spine injuries are common with water injuries. Again, people are in a pool, they dive off the shallow end, hurt their neck. Okay, we should always assume an unconscious patient has this spinal injury, and that's not just with water accidents, that's with everything. The unconscious patient, we should just assume that they have a spinal injury, so try to take C-spine precautions into consideration. All right, but CPR is more important than their C-spine. So if they are unconscious, they don't have a pulse, start CPR. We're not going to take our time to put a collar on this person. The CPR is more important, if that makes sense to you guys. But we're going to try to keep the body in a straight line, use a jaw thrust maneuver, because we want to try to consider that C-spine. Okay. A couple notes on the AED. Do not use the AED in the water. It will shock everybody who's touching the water. Okay. If the person is wet, we need to dry them off. Okay. Make sure you're not in the water when you shock. Okay. You might drag somebody out of a pool and there's a big puddle of water around them, and you put that AED on them, it's risking all of you. Okay. Make sure they're dried off. Make sure they're not sitting in a puddle. Make sure you're not kneeling in a puddle. Okay. Keep that in mind for water-related accidents. Diving accidents. Many patients in diving accidents are teenagers, just statistically. Okay. Injury could be from striking the board. There could be an object in the water. It could be a shallow water. Head, neck, spine, hands, feet, ribs. These are all things that are common diving injuries. Always assume the unconscious patient has a spinal injury. We already talked about that. I'm not going to beat that to death anymore. Scuba diving accidents. We have some scuba diving that happens in this county, in this area. I'm personally one of them. Another guy at work, him and I dive. We dive Chautauqua Lake sometimes. We have a dive team in this county. So there's training that takes place, up north on Lake Erie and in Chautauqua Lake. It's not real popular around here because our lake is kind of dark and dingy in most areas, but there is diving that happens. So there's a couple things to know about scuba diving. Okay, air embolisms. Gases leave the damaged lung and enter the bloodstream. It can be associated with divers who hold their breath, equipment failures, or attempts to conserve air. When you are scuba diving, you have to continue to breathe. You never, ever hold your breath. That's one of the first things that they teach you. So if you were to hold your breath, and I'm not going to get into the science behind it, but if you're real deep, take a big deep breath and hold it, and then you go up to the surface, that air actually expands in your lungs. because it's more compressed when you're deep underwater, and that can it can essentially pop your lung, and that can cause air embolisms, and so you get actually air going into your bloodstream, and that can cause a heart attack. Okay, very serious stuff. Diving is a very safe sport, but that's why they have training for it, so you can learn all these things that you need to know, so you can do it safely. But just keep in mind, air embolism can happen if somebody's holding their breath or they come up too fast, whatever the case is. Decompression sickness is another one. It's when a diver comes up too fast from a very deep, long dive. It usually takes 1 to 48 hours to appear. They say generally 3 hours, but there's a lot of variables. How deep were they? How long were they down there? How many dives did they do today? There's a certain process when you come up from a deep dive, from any dive really. You're supposed to stop at 15 feet and wait for 5 minutes, and that just kind of lets your body naturally decompress, because the water pressure when you're down 50 feet deep, and there's places in Chautauqua Lake that go down to 60, 80 feet, something like that. The deepest I've ever been in Chautauqua Lake is around 50 feet, but think about that. That's actually pretty deep underwater, and there's a lot of pressure on your body. You don't feel it when you're underwater, but you need to come up slowly. So if you shoot right to the surface, that your body's compressed, and you shoot right to the surface, and that air pressure change, that can really make you sick, and it can actually be fatal. So just for you guys to keep in mind, that was your scuba diving lesson for the day. How do we assess these people for air embolism? There's some symptoms you might see: blurred vision, chest pain, numbness in extremities, weakness, paralysis, frothy blood from the nose or mouth, convulsions, unconsciousness, respiratory or cardiac arrest. I know I read through those really quickly. I know this is something that you're not likely going to see very often. If it's something you're interested in getting involved in, as far as the dive team for the county goes, or just recreational scuba diving, feel free to reach out to me, and I can kind of explain the process of how to get certified. And it's fun. It's a good time. But likely in the EMS world, we're probably not going to be responding to these, but we could. So just add this to your broad knowledge of environmental injuries. Okay. Decompression sickness, we might see personality changes, fatigue, deep pain in the muscles and joints, mottling skin, numbness, choking, coughing, labored breathing, staggering, chest pain, unconsciousness. The biggest thing that I take from this is the decompression sickness is kind of like an overall like fatigue, the deep pain in the muscles, a little bit altered mental status. That unconsciousness, of course, is a very serious one, but those are more the common ones you're going to see if you were to ever see this. But how do we treat these? Okay, ABCs as usual, oxygen as necessary, rapid transport, notify the ER. Okay, so hyperbaric chambers I think the closest one to us right now is Pittsburgh. So hyperbaric chamber is basically an oxygen room where you can just get like full-on oxygen for a long period of time, and then they slowly kind of wean you off back to regular air. So if there's a true serious scuba diving accident in this area, they're going to have to go to Pittsburgh down there, because we don't have one of those hyperbaric chambers nearby. So keep that in mind too. And the scuba divers in this area are well aware of that too. So we try to be super careful, because we don't want to be put in that position. It's not like we have a hyperbaric chamber at in Jamestown. So this is kind of a specialized thing. All right, but keep the patient warm, keep them in the supine or recovery position. Okay, water rescue. So this does not make you certified in water rescues. There's a whole nother class for that. If that's something that you guys want to get involved in, for you guys in departments that have a lake in your actual district, it might behoove you to learn a little bit more about this stuff. There's a few things we can do, very basic things, to get somebody out of the water. If somebody's drowning or they're flailing around out in the water and we're on the dock or on the shore, okay, we can reach out to them. We can hold an object for them to grab, a big pole or something. Our fire apparatus usually have like rope throw bags, things like that. Flotation devices. Just the biggest thing for us to understand is that unless we are trained with the proper equipment, do not just jump out there to try to save somebody. They will drown you. Not because they hate you and they want you to die, but when you're panicking, when a person is panicking, they will do everything they can to pull themselves out of the water. And if that means pushing you down, they will do that. So keep that in mind. Don't just jump out in the water after somebody. Even with the life vest on, we have to use our equipment for this, because that will help them and help you not die. Okay, a little bit on insect bites and stings. I mean, what kind of stings and bites can we see around here? You know, one of the good things about this area of the country is we don't really have a lot of poisonous stuff. You know, we're not really rattlesnakes and, you know, copperheads and black widow spiders and all those kinds of things that are in the South. We don't really have a lot of that stuff here. So I guess that's a benefit. But we do have things in the, you know, bees. I'm personally allergic to bees, and, you know, insects, hornets and yellow jackets and wasps and all those different things. We can be exposed to those types of things. So how do we assess these people? Okay, gather info from the bystanders. Why are we there? Who called and why? Okay, do they have a medical ID device? Some people have a bracelet or a necklace that says I'm allergic to whatever. All right, but there's a ton of signs and symptoms when it comes to bites and stings. It can be anywhere from like a little bit of numbness or itchiness, like a mosquito bite, which we all have a reaction to that, or to straight out altered mental status. You might see like swelling of the mouth and lips and all that. And that's allergic reaction stuff that I'm not going to get into today. But these are all symptoms, insect bites and stings. Okay, so how do we treat those kinds of people? We do our ABCs as we do with all patients. Treat them for shock, call medical control, say, hey, this person was bit by a black widow spider that was a pet. And I mean, there are some exotic pets in the area too, though. Keep that in mind. Remove jewelry from the affected limb, kind of like we talked about with the burns. Somebody gets bit in the hand or stung in the hand or whatever it is, and they have a wedding band on, probably want to get that off because swelling is imminent. Okay, we don't want to have to cut those things off or lose a finger for that matter. Attempt to keep the limb immobilized and keep the patient still. Snake bites, ABCs, signs and symptoms. Again, a lot of different ones. Okay, rapid pulse, pain, labored breathing, altered mental status is seizures, profuse sweating. Those are big primary assessment things that you're going to notice for people. How do we treat these people though? Treat them for shock, because this could end up being shock, similar to anaphylactic shock, I suppose. So treat them for shock. You know, elevate the feet, keep them warm, locate fang marks if you can, and remove any jewelry on the extremity. Anaphylaxis will be covered in later. I think you already had this actually this time, but refer to that section for the pharmacology and allergic reactions, because that'll kind of pull all this together. Okay, this is where I would normally ask you guys questions, but since we're not meeting in person, you can feel free to email me any questions you have. I should see you guys next Thursday, not the 5th tomorrow, but the following week. I should be back to JCC. So if you have any questions, please reach out to us. If not, we will see you guys soon.